I have not yet used Quizartinib in patients with acute myeloid leukemia, but if it does get approved in the patients with FLT3-ITD mutated AML relapse refractory setting, I think it provides an excellent possibility for therapy for patients as a bridge to allogeneic stem cell transplantation. I say that because the drug seems to have a favorable toxicity profile, does not require inpatient hospitalization. The response rates were higher than what we saw with chemotherapy. The duration of those responses were longer than chemotherapy, and this translated into more patients having received Quizartinib, bridging to allogeneic transplant, which is the only potentially curative option. Now, one thing that we would consider for a patient who undergoes allogeneic stem cell transplant for FLT3-ITD mutated AML, who's already responded to a drug like Quizartinib, is then using Quizartinib as a maintenance. We don't have any data to support that yet, but I would imagine that I would consider that as an option given the high relapse rate in FLT3-ITD mutated patients even after allogeneic stem cell transplant. I think the question for all of us will be, if the drug is available in relapse refractory patients, will there be a temptation to consider the use of a more potent and more specific second generation drug such as Quizartinib in addition to initial chemotherapy and consolidation? Now, of course, we want to wait for the results of the Quantum First study to see if there's a benefit in terms of event-free survival, the primary endpoint of that study. However, on the other hand, if the drug is available and we do have safety data about the combination, I wouldn't be surprised if some of us would choose to use such an inhibitor as Quizartinib in place of midostaurin. The caveat there is it then supposes that the benefit that we saw from midostaurin was only due to inhibition of FLT3-ITD and TKD mutations. If that's not true and other enzymes are being inhibited, then there may not be a benefit of, or the same degree of benefit with Quizartinib. And so here there's much opinion around this point.
Quizartinib we can use in the clinical practice. If it's available, I think it will be approved first for relapsed and refractory patients, and it will be used as it's approved as single agent. However, I think there are several trials now looking also in the relapse and refractory setting whether Quizartinib can be combined with intensive chemotherapy even to improve the results for the single agent Quizartinib patient population. So I think it will be either used as single agent or in combination with a standard, let's say, salvage therapy in this patient population.
Now we have a number of new combination studies, which is personally what I'm really excited about with Quizartinib. So we have a frontline study in older AML patients who are not candidates for induction, where we're combining decitabine 10-day regimen, which is considered low intensity, with Quizartinib. And we also have a study of novel combinations where we're combining Quizartinib with another very exciting drug in AML called venetoclax. And we're also combining Quizartinib with an MDM2 inhibitor. So we think that these combinations are going to be very, very important, because one of the things we've seen is that although the response rates with FLT3 inhibitors are very, very good, 45–50%, the duration of response is quite short. It's usually in the range of 14 to 18 weeks. And so if you cannot get these patients quickly to a stem cell transplant, you really are not getting a very durable activity. So we believe that either by adding hypomethylating agents or chemotherapy, or rationally designed combinations such as venetoclax with FLT3 inhibitors, for which there's a lot of data published from our site and from AbbVie, or MDM2 inhibitor with Quizartinib, maybe we can increase this duration of response to 6 months, 9 months, 12 months, so that more patients have a longer benefit and also have a longer response, allowing them to go to stem cell transplant.